uh, running the running the complicated stuff. So I've got the very easy and the very pleasurable stuff to do tonight, and it gives me enormous pleasure to introduce Michael Ratcliffe, who many of you will already know. And Michael is going to give us one of his supremely detailed talks on plantar plate tears. Now, this is something I've been looking forward to ever since I heard it was going to be done. So I hope that you will enjoy it every bit as much as I'm going to enjoy it. So, as I say, welcome to everyone, but especially welcome to you as well, Michael.
Thank you. Thank you very much. My pleasure. My pleasure. And hello, everybody. Thank you for coming to join me on this presentation of a really, I think, important topic that's gaining a lot of traction as the years go by, as now a very common cause, as the title suggests, of metatarsalgia. So what we're going to do tonight is we're going to have a look at briefly the anatomy, just to see what it is, where it is, what it does. And then, knowing what it does, we're going to look how it gets injured, how it presents when it is injured, the problem, and then what tests we can do to actually make a reasonably firm diagnosis that that is the problem that we're seeing, and then what we can actually do about it as well. Okay, so if I may take the first slide, let's have a look at what the plantar plate actually is. Okay, so first slide, thank you.
Bear with me.
Okay, now, if ever you have been presented with a forefoot deformity, a digital deformity, such as the ones that you're seeing in various degrees, then you're probably looking at a plantar plate tear. This is the result of it, where we can see this dorsally elevated toe on the left-hand side here, quite extreme. In the middle, not so much. But then on the far right-hand side, we can see a separation, a V-ing, if you like, a medial deviation of that second toe. Now, all these particular photographs are taken of people who have a plantar plate tear. So if you've ever seen this particular injury, where the second toe, can be the third, less so the fourth, where there's that medial and dorsal deviation, that's what you're probably looking at. Okay, so if any of you haven't seen that, let's go for the second slide. Okay, so a bit of a busy slide, my apologies, but just so later on, what I will say is, after the presentation, if anyone would like the presentation, I'm going to give you my email address, and then you can just email me directly and I can send this to you. But let's get into it. So the plantar plate itself, if you look to the right-hand side, you'll see a dissected specimen of this, and you can see at the top of the slide a proximal phalanx. So this is the first bone in your lesser digits, the proximal phalanx, and then just proximal to that, you can see the shiny substance, the shiny looking structure, which is in fact the plantar plate. And you can see how it rests in relation to the proximal phalanx. It's at the base of the proximal phalanx. But also, look at this. Look how the plantar fascia actually blends into the plantar plate before both the distal plantar fascia and the plantar plate then connect, they join the proximal phalanx. And also look at the sort of the walls, if you like, around it, which are formed by these two major ligaments, which if we then look at the diagram on the right, on the left-hand side, we can see these two ligaments, the PCL and the ACL, the proper collateral ligament, and the accessory plantar ligament, and they form like a wall, a box, in which the metatarsal head sits. So it's surrounded by this powerful structure and held in place against the proximal phalanx. But the plantar plate itself then, as we can see from the shiny structure, actually lies then, it lies plantar to the metatarsal head, or deep to the metatarsal head, and the metatarsal head actually articulates with the plantar plate. So the plantar plate is a gliding surface. And the plantar plate, strangely enough, in many ways is, I think it's good to look at it as the bottom or the plantar aspect of the joint capsule. So if we look at the metatarsophalangeal joint, metatarsal head, metatarsal shaft, the proximal phalanx. It's surrounded thickly by this joint capsule, and the joint capsule on its base is thickened into the plantar plate. So in many ways, it's the base. And I think it's nicely put by a podiatrist from America called Kevin Kirby, who actually calls the plantar plate the distal extension of the plantar fascia. So if we think of the plantar fascia joining the base of the proximal phalanges, all 5 of them, but in particular the lesser ones, then we can think of the joining organ in many ways, not strictly, but in many ways we can think of it as the way the plantar fascia joins the proximal phalanx. It joins it via the plantar plate. And the plantar plate ligament not only is a joining of the plantar fascia to the proximal phalanx, but it also, as the picture shows, it also serves as an attachment point for these 2 ligaments, which are either side of that metatarsal head. So we can just see one side, the proper collateral ligament and the accessory collateral ligament. So both sides join into the plantar plate, as well as a structure that runs across all 5 metatarsal heads. The distal transverse, the deep transverse metatarsal ligament, which joins all 5 plates together, that attaches to the plantar plate, and also underneath the plantar plate run the what's called the flexor sheath, which is the sheath in which flexor digitorum longus and flexor digitorum brevis pass on their way to the proximal and then the intermediate and the distal phalanges, and something on top as well, which I'm not going to go into today, called the extensor expansion, which is like a tent over the top of, it's like a ridge tent over the top of the MTPJ, the metatarso-phalangeal joint. So this is quite an incredible structure. It's an anchor for these ligaments, these tendons, and for the plantar fascia. It's made of fibrocartilage. Now, when you hear the name fibrocartilage, everybody please think instantly compressive pressure, compression. As soon as you hear that name, fibrocartilage, think compressive pressure, because where there's compressive pressure in the body, there's always fibrocartilage, okay? And so it goes hand in hand. And fibrocartilage is made of collagen, principally, type 1 and type 2 collagen, this very parallel fiber, very strong arrangement of collagen. Plus, of course, chondrocytes, so cartilaginous pre-cells, if you like, precursor cells, chondrocytes. But in it also is a little bit of elastin because it has to be flexible as well. Okay, so that's what the plantar plate is. It's a gliding surface on which the metatarsal head rests and forms a big attachment point for lots of supportive structures of the metatarsophalangeal joint. So we can see how important it is. Next slide, please. Okay, now what does it actually do? Well, if we look at the top diagram, we can see in the far right-hand side, it says propulsive phase, okay? Now, excuse me, when you're propulsing, taking a step, and we look at the diagram underneath, there's a lot of pressure going from those metatarsals onto the floor. So basically the floor's pressing back against those metatarsal heads as you push off. So, as you push off, you're actually creating tension in the plantar fascia. It's something called the windlass mechanism. So when the big toe dorsiflexes and the lesser toes dorsiflex, you're actually creating a pull force along the plantar fascia, which pulls the feet together, if you like, keeps them together. But this is quite a force. It really is. And remember, the plantar fascia attaches to the proximal phalanges via the plantar plate. So the longitudinal force, this pulling force that goes through the plantar fascia and the plantar plate has to be resisted. So one of its jobs is to resist tensile stress, of which we do all the time when we walk and stand. Okay, so it has longitudinal collagenous fibers which resist that tensile stress. Okay, and so in many ways, it's I think it can be called a ligament, and this is why it's often known as a plantar plate ligament, because it has very regularly arranged collagen fibers. So whilst the joint capsule around the MTPJ is quite random in many ways, the collagen, where it becomes on the plantar surface, thickened into the plantar plate, those fibers become very regularly arranged to withstand these tensile stresses, and hence the name often it's given as a plantar plate ligament. Also, though, underneath these longitudinal fibers are transversely, so crisscross, like plywood, crisscross arrangement of these fibers, and these withstand pure compression stress. So you can see from that skeleton, I'm tipping up the skeleton of the foot there, and the little red arrow pressing down, those compressional forces, your body weight coming through your metatarsal heads into the ground are, if you like, absorbed, resisted, if you like, cushioned by the plantar plate and the fat pad beneath it. But principally, the met head rests on that plantar plate, pushing into it with all your body weight as you push off. And so those transverse fibers, okay, they resist and cushion that compressive stress. So we've got tensile stress, we've got compressional stress, and the plantar plate resists both of those. And finally then, because it acts as a connection point, an attachment point for the ligaments either side, the flexor tendons underneath, this structure on top called extensor expansion, and as we'll see later, the actual some of the extensor muscles too in some ways have a pull on it too. It forms a very, very important restraint for the metatarsophalangeal joint. Remember, the met head sits in that box, that sort of acetabulum, if you like, of structures, so it stays put. In other words, the plantar fascia makes sure the met head stays put and does its thing, okay, without drifting one way or the other, up or down too much. Okay, so that's the main function of the plantar plate. So quite an important one. Okay, next slide, please. Okay, just to show you then just a bit more detail about where it's located. And if you think of this picture on the right-hand side where you see dorsal skin, that's the dorsal skin of your foot, and there's been a transection slice right through the met head, okay? And we can see, if you look at, so on the notes it says, note the thick plantar plate, which is the arrowhead, so the filled in, just the arrowhead pointing underneath that metatarsal head. You can see that thickened band underneath there, okay? And that thickened band directly underneath the metatarsal head is the plantar plate, so it's quite thick. And it rests on top of the flexor tendons, notified by the letter F. So they have like a little groove within the plantar plate, if you like. And then underneath the plantar plate, shown by the red arrows, we can see these big, thick globules of fat, okay? And this is the fibrofatty padding which further cushions the metatarsal head. And anyone who's listened to the lecture I've given some time back about the structure of the fat pads, we know they're a bit like a bee's honeycomb arrangement of collagen walls with a lipocyte, a fat cell inside the collagen walls. So it's like a shock damper. So we've got the direct cushioning of the plantar plate on the met head as we push off, but further cushioning underneath to protect the skin as well as the structures. We've got the fat pad. And so if we look at the diagram underneath the first one, we can see the extent of the fat pad and just how thick that is as well. So a lot of cushioning for those met heads because the pressure they have to withstand is enormous and repetitive. Okay, thank you. Next slide. Okay, finally then with these diagrams, just to show you the size, get an idea of the size of this structure. Now the plantar plate itself, if we look at this diagram here, which is a wonderful paper, this Mass et al. Is a really super paper. If you full text available, just put Mass et al. Plantar plate, really nice paper. We get an idea of what this thing looks like. So from the top of the diagram, we can see the metatarsal, okay, the MT, the metatarsal, and we can see then where it says the word origin, we can see where both the joint capsule and the plantar plate starts. And then if we go a bit further on, it says the word insertion, and that's the base of the proximal phalanx. You can see where it says insertion, those longitudinal fibers. So that's where it starts. So from the met shaft to the base of the proximal phalanx, That's basically where the joint capsule and the plantar plate both start and finish. If we translate the plantar plate away from that diagram, so in other words, we follow the red dotted lines, we can see the structure that is concave on its upper surface and flat on its bottom surface. And basically, we can see just briefly, just at a point of interest, we can see the flexor tendons going underneath it. But look at this, it's 11 millimeters on average across, 19 millimeters long, and 2.5 millimeters deep. This is one big structure. And it's made of really strong collagen. So if you look at the ruler above, you can see what 11 millimeters looks like, and then almost 2 centimeters. So we're looking at quite a sizable structure here that is constantly under pressure, a pull pressure and a compression pressure. So quite a structure. Okay, thank you. Next slide, please. Okay, let's start looking at how it can get injured. Well, it's not fully understood, the injury mechanisms, but quite a lot is understood, and they can tear. This rectangular structure can tear. It can tear along one side or the other side, the medial or the lateral side. Rarely does it tear across directly, but it can. So the tear, if it's going to tear, usually happens underneath the second metatarsophalangeal joint. This is by far the most common. And so that statistic from Lachmans et al. Says between 60 to 90% of all plantar tears from their paper tear over the second metatarsophalangeal joint, a really, really common one. And it's more common in women than men and people over the age of 50 plus. Okay, so generally, if you're a man or a woman over 50, you're more at risk, but generally more women than men at risk of plantar plate tears. Okay, doesn't really happen that often in younger people unless it's traumatic, sports related or trauma related. But gradual wear and tear in men and women over 50, but in particular women, it's more of a wear and tear problem. And the order of tear, as we've heard, is the second metatarsophalangeal joint first, followed by the third, then the fourth, but never the fifth. The fifth has never had a case recorded. Could be wrong, but through my search, never recorded. So it's the second, more than the third, more than the fourth. And possibly because the second net head is the longest of all. So it takes a lot of pressure. Now, what is the biggest cause, one of the most common causes of pressure to the second metatarsal head and therefore to the plantar plate that causes it in the end to wear away and tear? Well, it's an incompetent first metatarsal or incompetent first ray. So look at the diagram, a normal one, when you're standing, all 5 mets are on the ground. And the first met bears the most pressure, as it should, being the thickest and the biggest. But where the first metatarsal doesn't bear weight properly, and commonly this is in hallux abductovalgus, so when you see somebody with a hallux abductovalgus and you have that raised dorsiflexed first metatarsal with the callus along the first proximal interphalangeal joint, that push-off callus, roll-off callus, and callus on the medial sort of edge, if you like, of that rotated first ray, it doesn't bear weight properly. And which one is left to bear all that push-off weight, or lots more of it? The second. The third and the fourth certainly, but mostly the second. And so second MTPJ plantar callus is quite common here. And so basically increased compressional stress, increased tensile stress can, after a long time, lead to a chronic injury in that plantar plate. And what actually happens is, first it starts to stretch, then as it stretches, basically it becomes less useful in its function, which is to resist that stretching stress and the compressional stress, and in the end then it tears. So elongation, attenuation, tear, injury. Okay, so that's one of the most common causes is wear and tear. Okay, next slide, please. Okay, but there are other causes too, and this is what I want to look at now. As we said before, the metatarsophalangeal joints are principally there. They're all 5 of them. Their function is to, via plantar flexion and dorsiflexion, but principally dorsal flexions, allow the foot to travel over them. So the proximal part of the foot travels over the metatarsophalangeal joints at push-off, and the toes are nice and extended, 5 levers, all gripping the ground, ready for that push-off. And that push-off you can see in the red circle in the diagram is known as the metatarsal break. So that's what we want. We want a good metatarsal break at push-off. However, the plantar plate is there to stop you hyperextending your toes at the metatarsophalangeal joint. So in other words, you don't want that foot to come so far over, say at 90 degrees or further, if you're pushing off, which is not good, because that puts a high level of tensile stress through both the plantar fascia and therefore the plantar plates. Now, if we look at some of these occupational or footwear related inducements, if you like, of hyperextension of the toes at the metatarsophalangeal joints, let's look at this high heel shoe here, this platform shoe, where we see this lovely scan picture of these toes almost at 90 degrees against the metatarsal shaft. So look at, where do you think that compressional stress is going? It's going directly down that metatarsal shaft into that plantar plate. Okay, so prolonged wearing of heels of this nature will create a high compressional loading of the plantar plate. Now, if we go to the next slide, let's look at this ballerina's demi-point position. So ballerina here is in demi-point, 90 degree almost angle of the proximal phalanx against the metatarsal shaft. But look at this, those metatarsal shafts are not pointing down as in the high heel, they've actually gone beyond. The compressional stress going through that plantar plate is extreme at this point. And these dancers, to be a ballerina or ballet dancer, you have to practice a lot from childhood into adulthood. And plantar plate injuries in dancers, because not just ballerinas, but many types of dance where this movement is performed, is quite common. And it can be devastating. It can really put an end to your career. And then, of course, just wearing tight shoes. So if we look in the right-hand picture, we can see those toes being hammered, okay, that proximal phalanx being extended up on at the metatarsophalangeal joint, sitting on top of the head. The pressure against those plantar plates, again, pardon me, the pressure is increased. And if this is a regular occurrence year in, year out, not only do you get the dorsal lesions, as you can see on the PIPJs here, of the toes, but also you get this retrograde pressure on the plantar plate. So as time goes by, years go by, this is what creates this triad, this elongation, attenuation, tear after a while, as that collagen degrades. Okay, so these are some further causes of what might cause a plantar plate tear. Of course, another cause is something like turf toe, where that toe, just a one-off, you may be totally healthy, but unfortunately you've slipped, you put your foot in the wrong way onto the ground, and it does rapidly, and that can be a traumatic tear. And that we see across the age span as well. But certainly these are more chronic causes, which are quite common. Okay, thank you. Next slide. Okay, so as I've said, this can happen as a rapid thing or a chronic thing. If it's rapid onset, you get generally plantar and dorsal metatarsophalangeal pain. It feels like it's a really intense ache and very, very unpleasant. But the more usual one is the gradual onset. As I said, this chronic overloading of the plantar plate. And that too creates pain, principally, again, plantar and dorsal metatarsophalangeal joint, particularly on palpation. So if you're palpating the dorsal and the plantar, pain will be the onset, but also is accompanied often by swelling because there's been a tear, there's been vascular damage too, and inflammatory changes are going on. And so dorsal swelling is quite common. You get plantar swelling, certainly, and if you hold the foot up towards you, you can see this quite sort of prominent plantar swelling, because that's where the plantar plate is, of course, and as that edema pushes against the fat pad, pushing it out, just an area. But it also happens dorsally as the edema finds itself into that dorsal space. And this is quite an interesting way of differentially diagnosing when you get a case of metatarsalgia, i.e. pain in the forefoot, and you think, could this be a Morton's neuroma? Well, generally, Morton's neuroma doesn't cause dorsal swelling. It would be unusual. So it's a way to differentially diagnose a plantar plate tear as opposed to a Morton's neuroma. Obviously, the Morton's neuroma pain is more of a stingy, sharp pain, and this is a dull, intense throb. Okay. General weight bearing causes pain. You're standing on this injured plantar plate, it hurts. Okay. But what happens is, if you then have to go on tiptoe, maybe you want to reach something, or maybe you're walking, and every time you push off, you are extending your proximal phalanx, you're getting that metatarsal break, it causes pain every time. And so and it can be quite debilitating. You sit down, the pain starts to recede. Oh, so that's another possible diagnostic tool. So pain and weight bearing, particularly when you're walking, or even if you're reaching on tiptoe. Then visually, here's a really nice one. We saw those pictures of those toes at the start of the presentation. Hammering of toes. That metatarsophalangeal joint is no longer stable, and you start to get hammering of toes. They can't grip as well. The plantar fascia now is damaged. It isn't able to attach through the plantar plate to the proximal phalanx. You can't. The flexor grip now is starting to be reduced. And also, remember, the plantar plate holds all those structures together, the collateral ligaments on either side, the flexor tendon underneath. Your metatarsal head starts to float out of this box, this acetabulum. It starts to lift, and so does your toe with it. And you start to get this sign, this telltale sign we saw, okay, which more about in a moment. But also, there can be a reduction of overall motion. So if you take the toe through its motion, the proximal phalanx through its motion on the NTPJ, on the metatarsophalangeal joint, it starts to reduce because it's becoming subluxated or even dislocated. Now, that can happen, this reduction of motion, it's not a definite sign because this really happens in osteoarthritis as well, where you also can get swelling on the dorsum. But the big difference between osteoarthritis is you get a bony hypertrophy in the joint. If you feel the second, the third, or the fourth metatarsophalangeal joint, you'll feel this stiff, bony enlargement, which is not so in a plantar plate tear. That gets a soft tissue swelling, but not the bony hypertrophy. So it's unlikely to be OA, although OA may happen later. Okay, osteoarthritis, sorry, by the way. Okay, next slide, please. Okay, here we go. This is a classic visual sign. This is known as the Churchill sign. If we look at Mr. Churchill there, his famous Victory V sign, this happens in the toes, and this is most commonly, it happens when there's been a plantar plate tear. You can have it also if there's been a collateral ligament tear, but much less common. Most likely to be a plantar plate tear, possibly with a collateral ligament tear. So, because the tear, now this is the interesting part, look at this second toe. Look how it deviates towards the hallux, medially deviates toward the hallux. And generally, when there is a tear, often the tear is on the lateral aspect of the plate. So the medial side gets a stronger pull with a still attached plantar fascia. So when you're standing and your met heads are bearing weight and that plantar fascia is being tensioned because those met heads are bearing weight, it gets a bigger pull on the medial side because the lateral side is torn, and it medially deviates. Hence why you get this medial drift and this Churchill sign. Okay, and Bavarian and Redcar show this. This is a great picture from a paper I can't recommend highly enough, or papers, by a UK podiatrist, Nick Knight, who deals in sports injuries. If you put his name in, Nick Knight, and plantar plate injury, lots of lovely papers. I recommend it absolutely to read. Nice, good read for you in the evening, I find. But also, what goes on beyond that? So, okay, we've had this medial drifting of the toe, but also now we're getting metatarsophalangeal joint instability. The flexor tendons now no longer have a route through this plantar plate. We have a problem now because we don't get this opposition of flexor and extensor tendons going on. And because the flexor tendons have a lesser strength in terms of gripping the ground, pulling that toe to the ground along with the torn plantar fascia, if you will, because remember the fascia is part of the plantar plate. So we can say that. The extensor tendon gets an advantage and it lifts that proximal phalanx. So the long extensor tendons, the extensor digitorum longus and brevis, are able to hyperextend the proximal phalanx on the metatarsophalangeal joint. Remember, the long extensors can't extend the toe fully when it's hyperextended at the metatarsophalangeal joint. This is one of these intricate dynamics where the lumbricals and the interossei muscles have to come in. But what happens in then is simply the extensor digitorum longus pulls up that proximal phalanx, and now the flexor tendons pull the intermediate and the distal phalanges down to the ground, and you get this classic hammering of the toe as well with reduced strength. Oh dear. So it's not looking so good for these poor toes now. Okay, next slide, please. Okay, here's a test that you can do that was first described by a scientist called Stainsby in 1997, and he called it the footstool edge test. Now, it's not a definite diagnosis, but it's very visual and very clear. And what he was saying, and Kevin Kirby is described later in one of his papers in 2017, another great paper to read, by the way, is when you stand on the ground, all 5 Met heads are pressing on the ground, and you get something called the reverse windlass mechanism. So in other words, you're standing on the ground, all 5 Met heads are on the ground, plantar fascia attaches to all 5 Met heads, and generally you've got a little bit of subtalar pronation, mid-tarsal joint pronation. So Met heads are on the ground, you're pronating to the ground, that plantar fascia gets pulled. But as soon as you stand on the ground, those Met heads receive that ground reaction force, that arrow coming up, and they get dorsiflexed. So they've all come down to the ground, you're standing on the ground, but now your full weight's on the Met heads, and they get dorsiflexed at their tarso-metatarsal joints. So you get the first Met cuneiform, second Met cuneiform, third Met cuneiform, fourth Met cuboid, fifth Met cuboid joint. The whole idea is then these tarso-metatarsal joints allow the metatarsal shafts to dorsiflex slightly as a shock absorbing mechanism, but that stretches the plantar fascia. And what it does is as soon as the metatarsal heads bear weight and dorsiflex slightly under weight bearing, because the plantar fascia is tension, this known as a reverse windlass mechanism, the toes are pulled down. The proximal fascia, the proximal phalanx is now pulled on the ground. So now your toes are all on the ground and you get this nice 5 through to 1. Your toes all come down to the ground as the Met heads receive weight. It requires no muscle action almost. It's all done automatically by the plantar fascia. And so that's what should happen. So in this, look at foot A on the edge of this block of wood here, this stool. When you stand on the edge and the metatarsal heads are dorsiflexed, the toes are plantarflexed because the plantar fascia is being pulled. Okay, and you can see it on toe A, but on toe B, this isn't the case. Look at these hammered toes and look at the fact they aren't bending beneath the edge of the stool. So in other words, the plantar fascia here, the plantar plates here are not doing their job properly. They could have torn or they may be elongated. Okay, so this is one thing you could try. All right, so it's not a definite, okay, but it is a good start, and it's called the footstool edge test. So in other words, you stand on the edge of the footstool. When you do that, the toes should flex below the level of the footstool. If they don't, could be there's a plantar plate tear. Okay, next stage. Next slide, sorry. Here's another test, which is quite a good one actually for this. And remember we said we lose grip strength as that toe hammers. The extensor pulls up the toe, the flexors have less power because the plantar plate is damaged through which they run. And so you can't grip the ground as much. Here's a test you can do to try this, particularly with the second toe, as you can see with a piece of paper. Take a piece of paper, 1 centimeter wide, 8 centimeters long, and place it about a third underneath the toe, and the rest you can pull. Ask the patient what's being standing, so they get plenty of pressure, to plantarflex that toe and hold onto that paper dearly. Press that toe down against the ground, hold onto that paper. If you can pull it out easily, then basically you've got a positive test for a damaged plantar plate and capsular structure. So if you can just pull it out with relative ease, then you know that's not good. If the patient's able to hold it so firmly against the ground that the paper snaps, then it's unlikely, basically, you've got a plantar plate tear there. So if they can't prevent that paper from being pulled out, probably got a tear. If they can prevent it, probably not. Okay, right, so if we go to the next slide. Okay, now this is probably one of the most important tests for plantar plate tears. And this one really is also you can actually grade this test. Now, I've taken a fairly simple approach to it, one I use, because I've got, I've got two patients, actually two elderly patients with this problem. But this is the one I test, but you can grade this actual test. And so can I refer you to a paper by Thompson and Hamilton in 1985, and they grade this. Now, I find you have to be quite sort of practiced to grade it, okay, but here's the way I do it, okay. So with the patient sitting down, what you do is you stabilize, as you can see with the left hand in this picture, you stabilize the metatarsal head, so you grip it both plantarly and dorsally, but just proximal to the met heads, because you don't want to pinch the met head too much because it could hurt the patient. So the metatarsal shaft just behind the met head, okay. Then you take a hold of the proximal phalanx of the toe, and you literally just very gently move it up, not dorsiflexion, plantarflexion, but a glide movement. So in other words, I don't know if you can all see my hands here. Are my hands visible, Martin, on this?
Yes, they are.
Yeah. See, okay, so this is just, my left hand is just behind the met head. My right hand is on the proximal phalanx, and you just shift it up and down. You don't move it like this, like the toes moving, you just shift it up and down. You shift the proximal phalanx up and down against the met head. And that, a glide movement, shouldn't happen. Only a little bit, should only be a tiny, tiny bit if the plantar plate is intact. If you can move it up by 2 millimeters and down by 2 millimeters, or around that amount, it's not looking good. Okay, it should be pretty stable. So if my finger's here, like that, and I move it, I can barely, try it this way, I can barely move it. But if it shifts up and down quite freely, by about 2 millimeters either way, chances are you've got a plantar plate tear, okay? And it will reproduce the patient's pain as well. It could hurt, so you have to be careful with this one. So you shift that proximal phalanx up and down against a stable met head, and it shouldn't budge much at all. But if it budges a lot, and principally if it goes dorsally, okay, so if it really shifts dorsally a lot, and certainly more than plantar, although plantar a bit, but if it goes a lot dorsally, then chances are that plantar plate is torn, okay, and it will hurt, okay. And in some cases, where the toe is really cocked up, like you saw in the first picture, on the first part of the presentation, if you can't even bring it down, if you can't even bring that toe down at all, you can't sort of relocate it, if you like, then chances are it's a plantar plate tear. So this is quite a good one. Worth reading that paper, Thompson and Hamilton, 1987, about the grades of it, okay? But this is a really quite a telltale one. So we've got the foot stool edge test, we've got the grip test, and now we've got what's called either the Lachmans test or a drawer test, if you like, is another word for it. These are good tests that can help establish that diagnosis. Okay, next slide, please. Obviously, as well as swelling, pain, and the V sign as well. Okay, okay, what do we do about it? Okay, so we've identified a plantar plate tear. We think the person's got one, okay? They're hurting, they've got the dorsal swelling, plantar swelling. We've done a positive Lachmans test. It's really shifted upwards. They can't put their toes down when they're standing on the edge of the stool. They can't grip a piece of paper. Chances are that metatarsophalangeal joint is damaged. The first thing we must do is we must protect that structure. Or my motto is always offload, overload. So we want to offload the tensile stress, and we want to offload the compressional stress. Okay, so offload, overload. So we want to protect that plantar plate and reduce the pain for your patient who's hurting. The first big thing, and this is not easy for the person to do, and I think it has to be explained carefully and with sensitivity, is no barefoot walking inside the house or outside the house, and particularly on hard surfaces. Wooden floors maybe inside the house, stone surfaces, and certainly pavements and things or pathways outside the house. Barefoot walking is a big zero, okay? Because you're stressing that structure. The compressional stress, the longitudinal stress is still going on big time. And so now here's where the negotiation has to be done sensitively. Please, inside the house and outside the house, curved footwear, such as what I'm showing here, and there is such a big choice out there. So a rocker bottom sole, such as we can see here, and inside and outside the house for about 4 weeks. It's not easy, but we have to do it because a rocker sole takes off the longitudinal stress. It stops the need for the proximal phalanx to extend or dorsiflex against the head. It's done by the sole. So it takes that longitudinal stress away, and the cushioning underneath helps the compressional stress as well. And so training shoes, walking shoes, anything but the sole you can't pick up the shoe and wring it like a wet dishcloth. The midsole has to be stiff. So a stiff rocker bottom sole is really, really a great start. It will help reduce the pain rapidly and restore function quite quickly to the person walking, giving them hope to carry on with the things you have to do after this. The next thing to do is please don't take long strides. The longer stride you take, the more you dorsiflex your toes, the bigger the metatarsal break. So don't necessarily shorten your stride, don't shuffle or things, but just don't take quick strides where your body's leaning forward and you're pushing off hard and you're really having a massive metatarsal break. No, just walk. Imagine you have something on the top of your head, you're having to balance your head, your chin is up, you're looking ahead of you, you're taking a shorter stride. So a larger cadence, a bigger number of steps, but a shorter stride length is really, really important. So the big thing then, to start off the protection, is this. Stiff-soled, rocker-bottom style shoes, in and out of doors, first 4 weeks, no barefoot walking, not good, but this is important for this type of injury, and reduce your stride length. Okay, next slide, please. Now, here's the other big player in getting better. This is the really, really good one as well, is tape that toe down in adjacent to the other toes. Bring back the function of that toe if you can. Now, in some cases, that toe is so dislocated, it can't be brought right down, but bring it down comfortably as far as it will go. Don't pull it down so the poor thing is right down so it really hurts the patient. Bring it down as far as it will go simply, but ideally to the adjacent to the other toes. And we do it with what I call the charity ribbon strap. So you need fairly wide. It needs to be about 2.5 centimeters so it doesn't become like a tourniquet across the toe. And it has to be taped down as it shows in the diagram here with long straps underneath the foot so it stays in place as the person walks. Okay, maybe not always as long as this. Now, you can use sport strapping. You can use a non-stretch strapping, a zinc oxide style tape, that's fine. You can also use, and I use one called Haploband, which has a slight stretch in it. So it stretches slightly, it allows a tiny bit of play in that toe. I prefer this for my elderly patients. With a younger patient with a trauma, you might not want to have any play, so you want to go for sports strapping. But where I go for my elderly patients where there's already a degree of subluxation there, I want to allow just a little bit of movement. So I have a tape with a tiny bit of stretch factor in it, and the one I use is Haploband, and it looks like this underneath the foot. It's not white, it's brown, but I put it in that arrangement. Now, this tape stays on pretty much all the time. Okay, so it has to be comfortable. You change it once every second or third day because you wear it through baths and showers, and after that it may well be peeling off and losing its effectiveness. And you do this for around about 8 weeks. That's a long time. And so it's hard. The patient has to keep this on. Can they do it themselves? well, their hands may be damaged, they may not be able to reach their feet. You have to assess if this is something that can be done, or somebody might be able to do it for them if they're shown how to do this. Okay, but it's a really good idea. Yeah, we will. I just see this little question come out. We'll deal with that very shortly. Now, this toe then is the important part. So we got the shoes, we got the stride length, and we got the taping. But the taping will carry on past the shoes. Okay. So let's next slide, please. Okay, continuing this. These are the activities you should avoid. So when you're looking to advise your patient, please, if they're into their sports or if they're into any of these type of activities, they must avoid them. So no running, okay? Whether you're a midfoot striker, a rear foot striker, it doesn't matter, because running often asks for a larger mid-tarsal joint break. Not always, but it often, running might have been the straw that broke the camel's back. So running is to cease for at least 2 weeks. Also, can we see this lady doing the lunge? Look at that foot, the back foot. Look at that metatarsal break. Lunging is absolutely out, okay? This will further damage that plantar plate. So anything like that lunge is not a good one, okay? The chap there, skipping, again, not a good one because you're landing heavily on your forefoot. High levels of compressional stress as you skip, okay? So these forms of exercise of themselves excellent, but they must cease while this is while you're trying to heal. So dancing as well, as we've seen with the ballerina, but other types of dancing too, running, even hiking long distance for the first 2 weeks, please, must cease. Okay, but also these static exercises too must cease for at least the first 2 weeks. So we're trying to offload, overload. Eventually, we will gradually reload. So my motto is always offload, overload, gradual reload. But in the first instance, offload, overload with these activities. Next slide, please. Okay, the person's come to you. You've given the footwear advice. Okay, as a temporary measure, you might want to offload that compressional stress off that metatarsal head. And you can do this with good old felt padding. Okay, so plantar cover, U'd plantar cover, principally over the affected toe, in this case the second, but it could be the third, could be the fourth. 5mm is okay, and I can understand that from a footwear point of view, but it's better if it's 7mm. You need that additional thickness to get further offloading. 7mm will reduce the pressure on that metatarsal head by around between 30 and 40% of its original pressure, for about a week, that is, before the felt crushes. So you've got the taping there, you've got the U'd plantar cover. This will be great at offloading those areas. So you're protecting the plantar plate, you're reducing the dorsiflexion of the toe, you're reducing the compressional stress. But the next stage is, felt is only a temporary intervention. The next stage is to persuade the person to have either an insole in their shoe or an orthosis with a metatarsal dome and a cutout. So let's have a look at those with the next slide. This goes on straight away as well, by the way. This is something you'd look to do almost immediately with the footwear advice and the activity modification and the taping. So here we have a 3/4 length orthosis. On top of that is a met dome or a plantar metatarsal pad. And basically, this pad should sit proximal to the metatarsal heads, okay? So not on them and not distal to them, but behind the metatarsal head. Because what this pad does is it dorsiflexes the metatarsal head and aids flexion of the toe, therefore offloading that stress going through the plantar plate, okay? Now, if you want an insole instead, I wore this insole for quite some time so you can see the demarcations of the met heads and the toes in the picture, I think a little bit. You can use an insole as well to put in the shoe, and you put the metatarsal dome or the plantar metatarsal pad again proximal to the metatarsal head as demarcated by the X there, okay? But now, that's only part of it. The next part that you can really help with is on the top of your insole or on your orthosis, is you can put a plantar cover, such as the one I've done, that covers the metatarsal pad, as you can, I think, roughly see in this picture, you can just see the impression of the metatarsal pad underneath the poron cover. You can see the X where the metatarsal head is, and then distal to the met head, you do the U. So you don't put the U around the met head this time, okay? Don't put it there. Let the met head sit on the cushioning, but let the toe drop into the space. So what we're doing is we're getting a little hollow, we're creating a hollow for the proximal phalanx and the rest of the toe to drop into, okay? So this can be either on an insole, if that's what the patient can wear in their shoe, or it can be an orthosis where the extension, the if you like, the extension beyond the end of the orthosis, where it ends behind the met heads, has that sort of sulcus extension, if you like. But remember, the met head should sit on it, not fall into the hole. That's quite important, okay? You want to dorsiflex the met, but let the toe flex to offset that longitudinal pressure, tensile pressure, and compressional pressure on the plantar plate. Okay, next slide, please. This all goes on at the same time, by the way. You do all this as fast as you can. Now, strengthening. When most people, there's no strong research behind this, but generally, people who get a plantar plate tear will often have a tight calf muscles, tight gastrocnemius. Now, gastrocnemius, when it's tight, along with soleus, is one of the major causes of subtalar joint and metatarsal joint pronation beyond mid-stance. It's the only way dorsiflexion can be got through the subtalar and metatarsal joints that isn't coming from the ankle joint because the gastrocnemius is tight. So that's why it's always good to wear a slightly heeled shoe if you've got a tight gastrocnemius. And certainly those shoes I showed with the slight rocker sole, not the complete rocker sole, not a big one, but where certainly the distal third of the sole points upwards, has a heel in it, a heel to sole height difference to take off that tension. However, I always think it's a great idea to ask your patients to do light dorsiflexion stretching. So quite simply, they sit down and they pull their foot up towards them. Okay, not the toes, leave the toes loose. This is important, leave the toes loose, just use the anterior tibial muscle to dorsiflex, and try not to pull your toes back, you don't want to do that, okay? Just pull your foot towards you using your tib-ant muscle, hold for a few seconds, let it go, okay? Do this around about 3 times 15 a day if you can. More would be better, but whilst you're seated, maybe watching telly or seated for whatever reason, do that pull up, hold for a few seconds, let go. Just keep it going, okay? Many of my patients are elderly, and the ones who do get the plantar plate tears, they've got quite profound gastrocnemius tightness. So I don't want them, and certainly I don't want them to do against a wall. I don't want them in any way flexing over that, running the risk of going up onto their toes at all. So I like to do it while they're seated. So this is a light stretch, okay? And the other one I think is so important is gluteal contractions. Now, actually, sorry, I need to go back a moment, forgive me. Flexor stabilization, I'll put in red. If somebody's got tight gastrocnemius, one of the things they do to get a nice rigid lever of a foot when they push off is they claw their toes. They use their flexors to stabilize their foot. That's what we don't want. We don't want that longitudinal and compressional stress going through the plantar plate. So tight gastrocnemius can cause flexor stabilization, which is a very common cause of toe hammering. So we want to stop that by stretching that gastrocnemius. So this is a background exercise I give. The other one is the gluteal contractions, where you're standing and you just squeeze your buttocks together hard as you can for 4 seconds, once an hour, for the rest of your life, really. It's what it does, it's a really great exercise for people who've been overpronating beyond mid-stance to get that back a bit, get those external rotator muscles back into play. Gluteus medius, vastus medialis around the knee, and tibialis posterior all helped massively by this. If you get an opportunity, stand up, okay? Stand up, don't hold your breath, just clench your bum as hard as you can. Feel your vastus medialis tighten. Feel your arch lift a bit. Feel your pelvis posteriorly rotate. This is great for bum and tum muscles, okay? It's the pelvic floor exercise, basically. So I give these two exercises as background exercises every time, okay? And again, can you do these exercises enough? You should almost make a daily habit of them anyway, particularly if you've got gastric tightness. But okay, the gastric tight one for at least 8 weeks, the gluteal squeezing should really do it all every day anyway, okay? It's a great exercise to do for general postural well-being. Okay, next slide, please. Okay, now, and then after about 4 weeks, okay, has passed, you're in the shoes, you've doing the background exercising, you've got the taping going on, you've got the insole in your shoe, okay? Then, this is me, I tend to start toe exercises because I'm hoping now that quite a bit of healing has started in that plantar plate, okay? That collagen has started to become less attenuated, or that tear started to repair itself, okay? Doesn't always, but where there is some relocation of that toe, where there's hope for that toe, then it'll hopefully start to repair. And after 4 weeks, I start then to promote toe function, okay? And these are the two I like to give. The bottom one is the most important one. And again, I draw on Nick Knight's term because I quite like this. He calls them toe press-ups, or it could be known as short foot exercising, or foot doming is another term used. Basically, you hold your toes out straight in front of you and you press the pads down, keeping the toes straight. You don't do the top exercise, you don't curl the toe towards you. You keep your toe flat on the ground and you press the pad to the ground. So you're almost lifting the metatarsal up. Okay, you're raising the metatarsal. Okay, you see my hand, you're doing that with your foot. And that is the movement that you want to restore. That restores strength in your lumbrical muscles, your interossei muscles, and your flexor, your flexor digitorum brevis. Okay, principally these very important extending muscles. Okay, and you should do them generally about 15 times, 15-foot domes, about 3 times a day for probably about the first 2 weeks, and then move on to 5 times a day. Obviously, you're writing all this down for your patient because it's a lot to remember, okay, and it becomes a routine. Then, the other one you can give, although I'm not so necessarily hot on this one, is where you're grabbing the towel, grabbing the pencil, okay, you're grabbing, okay. You grab, you let go, you grab, you let go, okay. And again, maybe twice a day times 15. But I prefer, particularly with my patients, the short foot maneuver in the diagram there. Okay, that really strengthens those feet and it really helps toe function return. But obviously, you're guided by pain. If it hurts your patient, then they have to reduce it or stop it until they're ready to do it. Okay, so 4 weeks have passed, then you introduce this. Okay, next slide, please. Okay, finally, 6 weeks have passed. The pain should have significantly gone. The swelling should have gone down and function should be improved. However, where there's non-reducible, unreducible deformity, then hopefully the pain has gone, but you might not want to expect, it's unlikely that you might be able to fully restore the toe to where it is, particularly if there's a hallux abductor valgus and the toe was overriding it. It may be that you have to continue the taping, okay? But what I would say is this, generally after 6 weeks, the pain has gone and some function has returned. However, usually the deformity, if it's profound, remains. And if the person wants to engage in vigorous activity or above their normal level, they should continue wearing those stiff-soled shoes with a slight heel raise in them, okay? Not necessarily rocker, they don't have to remain rocker, but if they're doing sports, they might want to have a training shoe with a distal part of the sole curves up, okay? Toe exercising should continue, and the proximal exercising, the gastric stretching, the bum squeezing should continue to stop re-injury. Strange enough, the loss of dorsiflexion is one of the major causes of instability as you stand, and one of the major causes of re-injury if you've gone over on your ankle joint as well. So re-establishing dorsiflexion at the ankle joint is a really key part of standing and posture and not being at risk of falling over too. So You might have, if you want to go on a long walk or you want to engage in sport, you might want to take that toe down and wear these stiffer sole shoes, okay? However, if you've done all that and there's no change whatsoever, there's lots of pain still, hasn't gone down, no restoration of that toe function, then at that stage, I would refer to the GP for an MRI to see plainly what's going on, to confirm if it is a plantar plate tear or something else, possibly a cortisone injection then to kill the pain, because this is inflammatory, and if necessary, then a possible referral for the surgical repair of both the plantar plate and the straightening of that toe, although obviously there can be consequences as a result of that. Okay, so the final slide now, please. So summary then, read that paper by Nick Knight, excellent. Okay, if you want to know, if you want to read a sort of summation of what I've said as well. Also, read the paper by Kevin Kirby on how this actually works, what this plantar plate does. It's a really nice paper. But in summary, no barefoot walking for 6 weeks. Do wear stiff sole shoes with a rocker style sole. Strap down that digit, changing every 2, but probably 3 days. Modify your activity. So there's no tiptoe standing, so running or skipping or those activities I showed you. So try to keep that to a minimum until later, until after the 6 weeks, that is, when you can start to redo them. Orthoses then with the modifications, the Met Dome and the proximal phalanx accommodation. And then finally, stretching and strengthening work. Stretch that gastrocnemius. Strength, work up your toe press-ups and your calf. But also there's another one you can do. I'll quickly show you. You can use a little TheraBand, a little like elastic band around the damaged toe and start flexing it against resistance and gradually build resistance. But I find that's probably more useful in younger patients, although you may disagree, but I found with my elderly patients, that's something they find tricky, although it's very specific to that toe and is very useful. Okay, so quite a lot going on there, but that's the plantar plate, a very important structure and a common cause of metatarsalgia and, you know, differential diagnosis of osteoarthritis or Morton neuroma or capsular damage as well. Okay, thank you very much indeed.
Michael, I absolutely found that fascinating. What I do love about your presentations is that you remind us, and you especially remind me, because I'm one of the world's worst, reaching for either for a needle or some other drug that I can put into people's bodies. But you remind us that there are some, I use the word simple, but they're not simple. They require a lot of knowledge. They require knowledge of knowing what you're doing and how to do it. But they remind us that sometimes non-drug therapies can be the most effective way to do things.
Yes, certainly. And Martin, thank you for bringing that up, because I did omit to say that you can manage the pain also through the classic inflammatory icing and non-steroidal anti-inflammatories as well. That helps as part of pain reduction. Yes, thank you as well. Yeah.
I must admit, talking about steroids and non-steroids, what I've done or what I've tried to do during this epidemic is to severely reduce my reliance on steroid injections or even oral steroids. Yes. So I haven't, either used them or prescribed them to any great extent. But I think it does occur to me that one of the things that this might lend itself to, and I'd like your opinion on it, is using substances such as osteotendon to be injected between the plantar plate and the articulation of the bone.
Well, this has been researched quite extensively in this area, and I would refer you to numerous papers. But yes, it is done as an aid to healing. But I think the principal thing, because anything that aids healing must have a background environment that is non-stressed as well. So those physical measures, I think, need to be put in place, as well as additional healing therapies that you described. Certainly, yeah, it's
absolutely,
yeah.
That has to be the initial go-to, doesn't it? And even while you're trying to do these other interventional therapies, I think that the ones you describe have to be the lead therapy for it. It's absolutely wonderful.
almost if you do nothing else, it's the footwear change and the taping is the big the big players here. But I did see a question earlier about rocker bottom shoes and gastrocnemius. I absolutely. I think what I describe is a rocker shoe with a distal sole pointing up principally, because a pure rocker one does have its own balance issues, and for the elderly that might be quite difficult for them. So the shoes I show on the presentation, and there are many like them, just have the toe curling up really. And I think because, as I've just seen a question here from Una, footwear needs to be carefully negotiated. And these things can be expensive. So there is a financial element in this too. But a stiff sole, certainly, not a flip-flop. Nothing where you have to curl your toes to keep it on. So no flip-flops. Yeah.
No, flip-flops are evil, horrible things.
Yeah, flip-flops are for limited use, and certainly not in this injury. So.
Right, well, we have, as usual, well run over our time. But Michael, I would like to give you sincere thanks for sharing your infinite knowledge with us. And I do hope you'll come back soon.
Well, thank you. Thank you very much indeed. Thank you. Oh, can I just give my email address just for people who want the presentation? It's the word. Oh, thank you. It's just the word training. So my email address is the word training at Cuxongerard. So I'll spell that CUXSONGERRARD.com. So training at Cuxongerard.com, and that comes straight to me. That's correct. Thanks, Jill.
Excellent. And I think, as you said, people would be more than welcome to an image of this presentation as a PDF, perhaps.
Yes, certainly, because of its own, it's a bit too big, but as a PDF, I think it's 1.2 megabytes, so it's quite sendable.
Much appreciated. That would be very, very useful indeed.
Well, thank you. Well, my pleasure. Thank you.
Right. Well, thank you again, Michael, and thank you everybody else for taking the time out from your evening to come and listen to Michael. But it's always worth doing, I have to say. So, could I ask you, Jill, by the way, what we've got next week? Now there, I put her on the spot, haven't I? Or maybe if Kirsten's there, Kirsten might be able to tell us.
Yeah, to be confirmed, Martin, to be confirmed.
Oh, to be confirmed. So it's a surprise. I love surprises. If you meet the nicest people, right, Michael? Okay. Right. Well, can I wish everybody good night and a peaceful night, and stay safe in these times. And thank you again, Michael, and I hope we'll speak to you soon.
Thank you very much indeed. Thank you.
Good night, everybody.
Bye-bye.